Hi, welcome to day 2 dermatology. I'm Magnus Lynch. I'm an academic dermatologist based at Guy's Hospital and King's College London. I hope you all enjoyed the talks yesterday, and we have another really exciting session within the dermatology track today. In our first session, we will have talks encompassing both skin cancer and inflammatory dermatology. In our second session, we will aim to understand the steps required for implementation of AI models within dermatology. And then finally, we'll be rejoining the other tracks for a wide-ranging discussion which aims to distill key principles for effective deployment of AI across medical specialties. So one thing that I'm often asked is whether dermatologists see AI as a threat. And I think many people don't realize that actually making a diagnosis is only a small part of the work that dermatologists do. Other aspects include discussing the diagnosis with patients, explaining where there's uncertainty in the diagnosis, and discussing the pros and cons of different treatment options. So in my experience, for this reason, many dermatologists see AI, in fact, as a powerful tool that has a potential to empower patients and to permit more effective and accurate methods of disease stratification and treatment monitoring. So with that in mind, now I'd like to hand over to Emily Bourgeot, who will chair the first session.
Hi, I'm Dr. Émilie Bourgeot, a Canadian board-certified dermatologist and co-founder and CEO of OroHealth and Dermago.ca. Thank you for taking the time to be here today. I'm very excited to be part of a group that strives to push boundaries in medicine with the goal of better patient care. We have some great speakers today. I'll introduce you to them shortly. In the next 5 minutes, I'd like to introduce you a bit to our projects in Canada and what we're doing with regards to AI and dermatology. So access to medical care is a big challenge worldwide, including in Canada. In 2018, my colleague and I co-founded Dermago.ca, the first Canadian virtual dermatology clinic. From the get-go, our goal was to provide increased access to patients for minor skin conditions. This clinic is addressed directly to patients and does not necessitate a consultation request. The patient consults Dermago and fills out the flow with medical information and the pertinent medical information before uploading pictures of the skin issue. After case submission, the patient will receive a diagnosis and treatment plan, and if needed, a prescription sent directly to the pharmacy. In the last few years, we've treated more than 15,000 patients this way with high satisfaction rates. This global pandemic has underlined the need for virtual healthcare reform and has opened the dialogue regards to our virtual care. I co-founded OroHealth in the spring of 2020 because I believe that medical professionals need to enhance their efficiency and provide asynchronous virtual care in order to provide care for all. OroHealth has 3 major pillars, including the hyper-secure Vault system, which provides the highest security standards on the market for medical records. Our Oro telemedicine platform, which sits on our Vault. It's a great solution for asynchronous medicine and is completely white label, which means it can be customized based on physician needs. And there's also Oro Smarts, which houses AI-based tools developed by our team of data scientists. These tools are used to assist physicians in consultation and follow-up care. If we focus a bit more on our smarts, more specifically the dermatology tool, SkinGo, the technology we designed, that is patent pending, combines 3 crucial aspects that mimic the reasoning of a dermatologist, resulting in a reliable and precise diagnosis and personalized treatment. So we provide contextual analysis with NLP. We also provide image analysis and evolution analysis with deep learning to analyze the evolution of the condition. The SkinGo algorithm currently diagnoses 26 minor skin conditions at a sensitivity rate of 92%. It is trained on our own data set with only 3,205 images, but we do have a data set that has more than 50,000 images. But with this beginning of training, it's very performant at 92% sensitivity. Our plan is to integrate this tool in our dermatology platform to provide the best product in the world for dermatologists to work and be efficient. It will also be available as standalone software. Now that I've shared all our great goals and our company profile, I'd like to introduce you to our great speakers today. First off, Dr. Magnus Lynch. He's a London-based consultant dermatologist, Mohs surgeon, and laser surgeon. Dr. Lynch is a highly experienced in all aspects of adult dermatology with particular expertise in skin surgery and the diagnosis and treatment of skin cancer. Dr. Lynch was a scholar at Christ's College, Cambridge, and graduated in medicine in 2003. He subsequently passed membership examinations for both the Royal College of Physicians and the Royal College of Surgeons, and then trained under leading dermatologists at the world-renowned St. John's Institute of Dermatology, gaining entry to this GMC Specialist Register, which is the UK equivalent of board certification in dermatology, in 2017. After completion of training in dermatology, he undertook a highly competitive fellowship in Mohs surgery and advanced dermatological surgery at St. John's, where he is now a consultant dermatologist and Mohs surgeon. Thank you for being here, Dr. Magnus Lynch.
Firstly, I'd like to thank the conference organisers for the opportunity to talk about our work. So just a little bit about me. I'm an academic dermatologist. My clinical work is based at St. John's Institute of Dermatology, which is part of Guy's Hospital in London. And I also lead a research group in the Centre for Stem Cells and Regenerative Medicine, King's College London. And my research group is interested in two things really. Firstly, understanding the structure and function of the skin using single cell genomics and spatial transcriptomics. And secondly, applying artificial intelligence within dermatology. So I'm incredibly excited about the potential for AI, and it's really great to have an opportunity to talk about some of the work that we've been doing. So what is artificial intelligence? I quite like this definition from the Oxford English Dictionary: the theory and development of computer systems able to perform tasks normally requiring human intelligence. And generally these days, artificial intelligence is used interchangeably with the term machine learning. So broadly speaking, then, artificial intelligence can describe any computer system, which can range from a simple rules-based system to a complex neural network. And although generally these days we are referring to algorithms which are able to make sense of more complex non-linear data. So tasks that we address with machine learning or artificial intelligence can broadly be divided into those where we have a lot of labeled data, and this is supervised learning, and those where we do not, and this is unsupervised learning. So automating aspects of dermatology with computer-aided image classification has actually been tried for many years or decades. However, previous efforts had very limited success. So within AI in dermatology, my lab is interested in all of these areas, although since this is a relatively short presentation, I'm just going to focus on a few, and those are skin cancer diagnosis, clinical risk stratification, and disease severity assessment. So I'm going to start off by talking about how AI has been applied within the domain of skin cancer, and then I will just give you a brief flavor of some of the other areas that we've been working on. So the concept of neural networks and the algorithms required to train them have broadly been known for decades. However, the available computational resources were not sufficient to train them. And as we can see, these available computational resources have been increasing on a broadly logarithmic scale for several decades. And in 2013, it was recognized that the graphical processing units, GPUs, which were originally developed for computer gaming, could be repurposed to help provide the massively parallel computational resources which are required for training of deep neural networks. So when we talk about deep neural networks, what we're really talking about is neural networks with multiple layers of hidden neurons. And within this category, convolutional neural networks detect features no matter where they occur in an input image, and these have far surpassed other methods of computational image classifications in many domains. So in 2017, Esteva et al. Published a landmark study in Nature, which was notable for being the first to compare a neural network's performance against that of dermatologists. Since that time, there's been a very large number of papers published looking at the applications of AI to skin cancer diagnosis. And one of the reasons that so many papers have been published in this area is the availability of large, publicly accessible, curated data sets such as this ISIC challenge dataset. And we'll come back to the importance of data availability later on. So Esteva et al. Used a pre-trained Inception version 3 Google network architecture, and they fine-tuned the network using a dataset of in excess of 120,000 clinical and dermoscopic images of skin cancer. So you'll be seeing a lot of these diagrams, which are called ROC curves, in this talk. And essentially, these are a way that we can visualize the trade-off between sensitivity and specificity. And this is a figure from a recent review article on AI that we published in the British Journal of Dermatology. Essentially, any classification system does have this trade-off between sensitivity and specificity. So, for example, if we're training a skin cancer classifier, the network will output a probability, and at a lower threshold, more melanomas will be captured, but at the expense of more false positives. And the ROC curve essentially evaluates the performance of the classifier across the full range of sensitivities. And by quantifying the area under this curve, the AU ROC, this gives us an overall measure of the performance of the classifier. So Esteva et al. For testing selected a subset of clinical and dermoscopic images, confirmed with biopsy, and asked over 20 dermatologists for their treatment decisions. And in several different categories, the average dermatologist was found to perform at a level below that of the AI classifier. So this table from our recent review article summarizes multiple studies that have been performed since that time, comparing the performance of AI classifiers and dermatologists in skin cancer diagnosis. It's a very busy slide, but essentially the conclusion is that all of these studies found AI to be superior to a dermatologist. And this does raise the question as to whether there may be some source of bias. In support of this, Han et al. Actually evaluated the Navrat Deshent et al. Evaluated the performance of a previously published AI classifier on a dataset to which it had not been exposed to during training, and found that whereas the reported AUC was 0.91, when it was exposed to a novel dataset, actually only achieved the correct diagnosis in 29 out of 100 lesions. So what might be potential sources of bias? Well, I've listed them here. Essentially, these can be divided up into bias favoring the AI and bias disadvantaging the clinicians. And I'm not going to read them all out, but one thing I will highlight is that in a recent Cochrane review, where the diagnostic sensitivity of dermatologists with dermoscopy was summarized, they found that approximately 92% sensitivity, and this is significantly higher than is reported in many of these AI studies. So in order to address some of these points, a UK-based company called Skin Analytics performed a prospective study of the AI classification of skin lesions. What they found was that at 100% sensitivity, their AI algorithm achieved specificity of 65% in comparison with 70%, which was achieved by dermatologists. Now, it has to be said that the design of this prospective study does not totally eliminate the aforementioned sources of bias, since it does focus on the selected group of lesions that were deemed sufficiently important to photograph, and it does omit the large proportion of lesions that would have been observed by a dermatologist on a full skin check but not deemed important. Nevertheless, it does suggest that, at least in the longer term, there's every reason to believe that AI will perform at or above the level of a human clinician. So we wanted to understand the potential mechanisms by which convolutional neural networks might potentially misclassify skin lesions. We also wanted to understand whether these were the same as those found for humans. We recently published this paper in the Journal of Investigative Dermatology, where we showed that subtle variations in color balance can deceive a convolutional neural network into classifying a melanoma as a harmless nevus. And importantly, this was not the case when humans were tested in a similar manner. We also showed that the orientation of the image and the position of the image affected the classification accuracy of a neural network. And again, this was not the case when we tested humans. So the European Union's GDPR requirement specifies explainability as a requirement for algorithmic decision-making, and this is not currently achievable for AI-based clinical systems. So what do we mean by explainable AI? Well, essentially, we want the AI not only to tell us what it's predicting, but also how it's come to that decision. So explainable AI is a great deal of work going on in this area. Here's an example of where we have plotted a visualization of the areas of the image which are contributing the most to the neural network's decision-making process. And these types of approaches will become increasingly important as neural networks are deployed in a clinical setting. So due to time limitations, I'm just going to give you a very brief flavor of some of the other areas that we're working on. So first one is psoriasis. So psoriasis is a chronic inflammatory disease which is associated with multimorbidity. Disease severity is currently evaluated with a scoring system known as the PASI score. And this evaluates a number of factors, but most importantly, the affected body surface area. This PASI score is subjective and poorly reproducible. Nevertheless, it's used for all of the major treatment decisions, in addition to multi-billion-dollar clinical trials. So we've developed an AI system that can automatically quantify areas of psoriasis on the skin. In the middle panel here, you can see where the AI system has detected body parts. And on the right panel, you can see the segmentation of the psoriasis rash. And we're planning to evaluate this in a prospective clinical trial. Another area is skin allergy. We develop allergies to a wide range of substances that we come into contact with. And this is a major clinical and public health challenge. So based upon demographic information, including age, sex, site, duration, and occupation, we found that we can predict the risk of cutaneous allergy. This is a figure from a paper that's currently in revision, so please don't share the data. But what we found is that more advanced machine learning models, such as gradient boosting, outperform conventional logistic regression models. And this likely reflects the ability of these more complex models to capture complex nonlinear relationships in the input data. So I briefly mentioned at the beginning of the talk the importance of having sufficient data for training. And this is currently a major limitation for many of the studies which we're aiming to do within dermatology. I'm working on obtaining ethical approval for the collection of training data in the hospitals in which I work. However, what's really needed is a joined up national approach. There is a growing consensus amongst dermatologists that this is what we should aim for. So in conclusion, artificial intelligence will no doubt have a large impact within dermatology, and it has the potential to free clinicians' time for the management of more complex cases. Development is currently most advanced for skin cancer recognition and classification. However, there is the potential to apply AI to stratification and risk prediction for inflammatory skin disease as well. And finally, there's a need to standardize and create national frameworks for the collation and collection of anonymized training data and for the evaluation of AI technologies within dermatology. So this is the members of my research group who've contributed to this work, including Clarice Gagne, who's a postdoc, Nazrat Haran, who's a research assistant, Bo Wan, who's a clinical research fellow, and Zinyu Harper, who is a PhD student and clinical research fellow. And these are my collaborators. I'll be very happy to take any questions. Thank you.
Dr. Christoph Hugh is a practicing dermatologist trained in Geneva, Switzerland, and Singapore. Currently in private practice since 2010, he is a consultant of teledermatology and artificial intelligence at the University of Basel, an editor to the JAD and GADV, and a board member of the International Society of Teledermatology. He manages the PASSION Project, a global health collaborative which aims to augment teledermatology through the use of AI to diagnose common conditions in the pediatric population. His special interests are digital health and social media in dermatology. Welcome, Dr. Hsu.
Thank you for inviting me to present here at AI Med. I'm very honored to be speaking this session, and we have a good panel of speakers, and I will do my best to bring my part to how I can find AI and machine learning to find solutions for skin problems, where there are few dermatologists. So if this presentation is too long, you can go directly on telederm.ai and learn more about the project, the teams, and also reach out to us or me to foster our discussions. So this conference is really about finding solutions using artificial intelligence, but that is only possible if funders and different providers of a service from people who actually have the problems to the people who can actually help solve them. They have to be on a par, and this is usually done on a global scale in international organizations. And that's why I'm going to talk about first about the WHO solutions to the problems which have been identified on the African environment. Then I will talk about artificial intelligence in general. Then you will see that there's a lot in AI in dermatology or any health solution, which is more about reaching a model, but then you have to deploy the model. And that's also what Passion Project One aims to do, is that if we get an actionable model, we want to make sure it's really implementable in the real world. Then I'm going to update you on the status and the collaboration building possibilities. So let's start with dermatology in Africa. So dermatologists, various endangered species, I'd say. So only a few dermatologists per million in some countries like Tanzania or Madagascar, whereas the average would be in our rich countries, it could be 1 in 10,000. The advantage, nevertheless, that we still have a good a network coverage, so the dermatological expertise can be maintained even though there are no dermatologists or not enough of them. And this is also because triaging is what digital health can achieve through telemedicine. And this would be done through common conditions such as eczema, infection, so bacterial, fungal, and infestations, as well as insect bites. So now the problems on the global scale need to find global solutions. So people agree on the table that sustainable development goals are the way to achieve global health excellence. And this happens through the reduction of communicable disease, achieving healthcare coverage and inequalities, reducing them. So these are the goals. And now what are the means? So the means is really a technical one. So, and this is digital health, and the WHO is really aware of that. And the other is financial, of course, and these are funders which are aware of these problems. So I'm going to be, so why did we choose these conditions? They are very frequent, and usually we tend to think about dermatologies as a cosmetic Botox filler provider. But actually there are some conditions which can be very lead to morbidity. So look at scabies, it's a bit like COVID. You have one person in the room who is going to catch it, and then all of a sudden you don't even have time to catch the next gasp or breath that everyone in the room is contaminated. And scabies is a typical super infection source. And this can lead to impetigo. Impetigo can easily be managed, but it can also become a big problem if it's not treated. So now, what we thought about the hypothesis is that we talk with a team in China, a team in Tanzania, one in Madagascar, and we tried to see if we could achieve solutions using artificial intelligence. And some teams have joined us also. And this is the Northern Labs. And I think there have been some presentations by the speakers working for that company, as well as a speaker who actually worked on developing their model to recognize faulty skin conditions on pigmented skin. And we also have a team from Guinea who joined us. So briefly, how does supervised machine learning work? So I'll just mention here that we are using supervised learning because explainability in health is really important, and the possibility of labeling the data that we work on is definitely something which will help to that, even though some questions might remain. So basically, how does training a training of a model work? So basically, we need the oil, so that's data, preferably one we can collect, but also if in the effect of that, we can augment some data. I'll explain that. And then we need an algorithm, and that algorithm is nothing more than a mathematical rule. It's a bit like when you teach multiplication tables to your children, like 3 times 4 is 12. You can input that in a calculator and you'll get 12, which is the same result. And in both situations, you don't know how they reach the conclusion. And this candidate model that you reach, which has the correct answers, needs then to be deployed to become usable safely in the real world. So how do algorithms work? So basically it's neural networks. So basically you have the data which appears in the input layer, and then after the classification takes place, the classification classes are compared with the labeled data. And depending on what type of discrepancy or loss you get between what is predicted and what is actually true, the data is then is not retrained, but the algorithm is basically tweaked so that the ability with the validation and the training sets can be examined. Of course, we still need the test sets to check if the model really works. So why would we use Asian skin and Caucasian skin to learn African skin? Well, it's an easy answer. So it's a data, or rather the lack of it. So there's very little data on African skin, and we need to find ways in the meantime, of course, to collect data on African skin. So we are augmenting the data that we have on African skin and on Caucasian skin, Asian skin, using generative adversarial networks. So here's a simple picture, but imagine that the eyebrows, the nose, and the mouth are different would be fine features of a skin condition. Imagine it could be Danny Morgan falls for eczema, or it could be an eczematous plaque, or a patch of impetigo, which is the infection. And these would what we call core styles. And these core styles on existing people on the left would be integrated on the one on the right. And what's great about what we have on the right is that even though the person doesn't exist, it really integrates all the different styles which have been collected. So it's relevant to be used as data and mixed with the real samples which collect both data sets can be pulled together and used to train the algorithm. And of course, we need as well as experience. So the algorithm, if it has experience, it might still get it wrong, but at least it will be starting from a point where where there's enough experience, basically. So it will be through a technique called transfer learning. So transfer learning is basically recognizing the conditions are possible in one class. So let's say in Caucasian and Asian patients, and before the data is actually fed to the algorithm to train, this algorithm is transferred to the before the data set is fed. So in the end, what we need, of course, and this will not be replaced by these augmentation techniques, is more data. So we need to collect more. And of course, we need quality pictures, which are then labeled. And this is also a very labor-intensive undertake. Of course, now, as I was mentioning, so funding is very important. So that's the way of implementing projects, and foundations usually look at what is already recognized as a problem on a global scale. So we're working with a foundation called Fondation Botnar, which is based in Basel. So it's member, let's say, of both the digital aspect of things and the public health, global public health aspect of things. And it really aims to use artificial intelligence to solve health problems in the pediatric population. And again, why did we choose atopic dermatitis, impetigo, tinea, scabies, and insect bites? It's because they are 80% of what is seen on site, and there are management strategies available locally. So I had the other day a plastics, a general practitioner who was Michael Jackson's physician, and he was really he kind of asked me quite assertively, if I may say, why would you treat warts or acne, and why are you not including them in these 5 disease class? And my answer was, they are not amenable as management strategies locally. So the WHO has a really strict definition of what makes a good screening tool. And one of them is really that you need to be able to offer solutions to the problem you identify. And when a treatment, a cream to apply your acne, a problem, is something like half of your monthly salary, I don't think it's a practical solution to offer to people who are identified with this problem. So again, implementing, so it's going to be, now we're really on the creation of the model, and progressively we will be verifying man versus machine, man being the dermatologist, then the healthcare provider, and then the well, of course, the medical officer in between. And when we get a safe concordance of results, this solution can be rolled out to the real world. So now a little update on the current status. So COVID is there, unfortunately, for you, for me, and it is probably why we're having a virtual conference instead of a in-person one. So images collection is only about 10 or maybe 20% of what it should be currently. So it's a bit slow, and there have been team changes as well. So some teams have been more occupied by other healthcare issues, and this has explained the reduction of the involvement. But on the other hand, some others have joined us, and we have that wonderful team in India, and we also have a great team in Guinea, and these two are very active currently. So lack of data means some results which can be improved. We just ran a late run of data, and the level is not very good actually. But for eczema, it's not that bad actually. So we still get some accuracy on images for eczema, but of course that won't be also more relevant if we manage to get more data, and also questionnaires which actually are relevant to the data. For example, scabies, we all know it's non-specific, but if you have a history of a nocturnal itch or other people scratching and a history of not being that long, well, you can increase the probability that the patient has eczema and not atopic dermatitis. And this is the team I'd like to thank. I haven't included everyone. We have some advisors. So we have Professor Soyer in Australia. We have some Professor Pasquale in Spain for the image advice, but I haven't included everyone. And again, if you want to go on the Passion Project website, here it is. And I'll just finish with the 2 Telederm platforms that we're using. So one is web-based, and the other one is more smartphone-based, so Android and iPhone. And just to summarize these slides, the great advantage of teledermatology is not just reducing geographical barriers or actually reducing the risk of catching COVID. It's also adding a place to the workflow to diagnose healthcare problems. And this, for example, in teledermatology, it's basically putting yourself between a patient who wants to diagnose himself his problem and a patient and a doctor who's going to see the problem. So the possibility of telemedicine is one of triaging. So you can actually determine what needs to be seen fast and what can actually give a bit of management and see how it goes to actually improve the workflow and the quality of care for the patients. And I'll just finish with that website, which is called telemedskin.com. It's basically got a lot of information on teledermatology, on artificial intelligence in general for health and data, including the ethical aspects such as how we do good, how we avoid bad, how we do justice, and how we achieve autonomy. And of course, there's and not of course, but there's also a dermatology part for if anyone's interested in learning continuing medical education in dermatology, you can register, and the registration purpose is really just to avoid having non-healthcare professionals being exposed to data they can things which could find offensive. So anyway, I would like to thank the organizers again for inviting me, and I hope you found the presentation interesting. Thank you.
Welcome everybody to the real-time applications of AI in dermatology session today. We'll be discussing how to establish a successful data science project and hope to demystify the process through a panel discussion. Our panelists today are Trevor Champagne from the University of Toronto, Roxana Danescu from Stanford University, Sharad Kumar from Neurothem Labs, and myself, Maria Wei, from the University of California, San Francisco. Today, we're going to be going over some challenges that we've identified in the AI and dermatology space. We'll be discussing how to bridge the gap between biomedical scientists and data computational scientists, how to create algorithms that are fair and generalizable, how to deal with clinical validation across skin types, and how to guide users, the stakeholders, to take images consistently, and how to deal with resistance from the field of dermatology towards a commercial product aimed at general practitioners. And I will ask the panelists to introduce themselves. Trevor, perhaps you can start.
Sure. So hi, thank you for inviting me today. So I'm Trevor Champagne. I'm an assistant professor at U of T in Toronto, Ontario, Canada. So before medicine, I was a software developer for several years. And then I took the really long road and went back to medicine and then to dermatology. And so when I graduated, I really started looking at kind of tech and dermatology. So I've spent several years looking at virtual care. And then more recently, a lot of kind of smaller projects looking towards how can we use artificial intelligence, machine learning in virtual care pathways. So that's been the first and foremost of what I've been working on lately.
Thank you, Trevor. Roxana.
Yes, so hi, I'm Roxana. I'm at Stanford currently, and I did my MD PhD at Stanford in genetics and bioinformatics, and have currently did training in dermatology, and after that started a postdoc working in a machine learning lab. And I work on basically developing algorithms to improve clinical workflows, looking at algorithmic fairness and generalizability for dermatology applications, and basically trying to develop the groundwork for how we develop these algorithms to be used clinically.
Thank you, Roxana. Sharad.
Hi, I'm Sharad. I have a bachelor's and master's in computer engineering, and I've spent a bulk of my 20-odd year career working for sort of chip design companies, doing sort of hardware development as well as sort of software. And I'm in this role kind of advising Neurothem Labs in terms of how to go about sort of designing their AI algorithms, as well as sort of testing the product in general.
Thank you, Sharad. I'm Maria Wei. I'm a professor of dermatology at the University of California, San Francisco, and I'm very interested in technology in increasing access to dermatologic care and to augment the accuracy of dermatologists and other practitioners in the clinic. And we've been working on different ways to do that, different parallel ways with image analysis, as well as developing markers for tumor progression. I have a bachelor's in computer science, but I've mostly worked in medicine and have come full circle now back to my roots. Okay, well, let's get started on the discussion. And one of the things that I found early on when I first started in this field was when I collaborated with data scientists, there was a bit of a culture difference. And I had initially a rather rocky collaboration, and I learned from that. And now I have a very fruitful collaboration that's been going on for several years. But I wondered if the rest of you have had that. And in my case, it was mostly it was a divergence in a sense of timeline. So there was a difference in timeline in data acquisition and pre-processing versus data analysis computationally. And there is a vast difference in biomedical research timeline and computational timelines. And that's what we came across. And we didn't really realize that. I think we were quite naive. I think probably now people have more realization of that. But that was one early barrier that I encountered. And I'd like to hear if others have had that situation and how they overcame it.
Yeah, I think the thing is understanding both cultures it can be very helpful. So, you know, the hacker computer science culture is move fast and break things. And I always say like, well, you can't move fast and break things in medicine because you have, you know, you have humans involved, because when you're doing sort of iterative software development, maybe the stakes are not as high when human health is not the issue. So I think just having language around that and just understanding that that's where your collaborators are coming from. I kind of sit in the middle of both worlds. I've worked on kind of both sides. So I think that that helps. And I just sort of, you know, for the purely computational people, I kind of sit and explain, like, give examples of like things where patient harm has been done because, you know, a trial wasn't done in the appropriate way, or how like what we do can actually impact people. And I think that kind of clarifies it, because you know, we as clinicians have experience with how, you know, we do clinical trials to validate things and how patient care happens, and how if we change something too quickly without validating it, it could be detrimental to patient care. And I think it's just important for us to like put those into words and explain it. And then also acknowledge that we understand that outside of patient care, things are done very differently, things are done much quicker, and just sort of, you know, orient the people that we're working with to the culture in medicine.
Exactly. I like that contrast between move fast and break things versus let's keep people healthy, right? Trevor, have you experienced this? I know you started out in software and then you moved into medicine. So perhaps you have the reverse path that many of us have had.
Yeah, so, but I agree 100%. There's a disconnect because it's so easy to just put a piece of software out there and get feedback and change it, and get feedback and change it. But it's like the culture of medicine is not to do that. It's not safe to just put things out there and, you know, experiment and learn by failing over and over again, which is what so much of software development is. It's just keep trying until something works, which works for the initial development phase. It's like, but when you're ready to put it into actual practice, you can't just keep putting things out there and failing. So yeah, so like I agree 100%. It's like establishing that, you know, medicine has very careful timelines. This is the first step to a good collaboration.
Yes, and Sharad, how about from your standpoint, from a purely computational person? I'm sure you had frustrations with those in biomedical science.
Well, I would not say frustrations, but certainly sort of learnings. And I mean, to build upon what all of you said, I think when we first sort of started to look at sort of skin diseases, we sort of optimized the algorithms in a way that they would do very well for the conditions we were targeting. And we didn't really pay that much attention for the skin diseases, let us say, that were not part of what you were saying, the addressable set of conditions that we were looking at. And then the clinicians were, I mean, we got reasonably good results, but the doctors were, well, I tried it on this patient and they didn't have any of this disease and it still flags that condition. And I said, well, that's kind of low probability, but this is what we are targeting, because in computer science, this is the problem we are solving. But over time, we kind of learned that how to sort of find that balance in our algorithms. Because if you don't have the condition, rather than giving, let us say, a low probability for some condition, physicians very much wanted that we say, not in our list or not diagnosed by the AI. And that sort of tuning of the algorithms to be able to reject the conditions that were not part of what we were addressing, and fine tuning the algorithms for that. I mean, that took some time for us, and also was frustrating in the sense that we thought we'd attacked the problem, and now we were sort of reducing our accuracy or sensitivity and etc. for the classes that we were addressing, just to take care of the things that we, in my view, didn't really care about from a computer science point of view.
Yeah, the focus is different in the two different fields. One is optimizing the algorithm, and the other is dealing with humans and all of that entails. But I'm very interested to hear. So are you saying that you have tackled and solved the out of distribution problem in dermatology? Because this is a fundamental problem. We have so many diagnoses and so many disorders.
No, I can't say we have solved it. I think it is sort of a trade-off in how the algorithm parameters are set, such that you reduce the accuracy for the inbound conditions to get a higher number for out of bound. And then how do you play with these numbers so that you kind of, what is the sort of the optimal point? That search sort of compromised sort of our, I would say, the initial results, which looked very good for the inbound conditions. And that was the data we were originally working with. And that finding that balance and working with clinicians was sort of, I would say, our major sort of learning, and a lot of time spent in sort of optimizing the algorithms, figuring out what tuning we had. And yeah.
Yeah, very interesting, because I think that segues into our next challenge, which is how to create algorithms that are fair and generalizable. And I think that you're touching upon that when you talk about how do we deal with out of distribution diagnostic classes. Because as you know, in one area of the globe, there may be endemic disease that's not in another area of the globe. And so one issue is generalizability, but another is fair in terms of the training data sets. So how have you all dealt with that?
I mean, I think one thing that we're discussing here is we're discussing diagnostic algorithms. And I would actually ask people to really try to stretch their minds, because these, machine learning tools can do so much for us to improve our clinical workflows in ways that are not diagnosis. And to be honest, I myself do not work on diagnostic algorithms, because I feel like the data sets that we have available right now are not going to be able to create a fair generalizable tool that can truly do diagnosis. Like, we may be able to build decision support that works well in particular regions, as you were saying, like where we have the diseases that we see appropriately represented, and then by using it as decision support or augmentation of the clinician, you still have a physician sort of in the pipeline who can use their clinical decision making to make sure that if something is out of distribution, we don't have erratic algorithmic behavior, or if it's like a really rare disease that the algorithm can't even identify. So I think these are a lot of different issues. Personally, for me, I work on like showing some of the issues that we have with diagnostic algorithms right now, and then I focus on other types of tasks that I do think we could work on being able to do well, like things like monitoring, things like looking at photo quality. I think there are a lot of opportunities to like build tools, but a lot of people are focusing on diagnosis, and I think we still have a ways to go in that space before we have something that's truly like safe to be used clinically.
Yeah, so Roxana, expanding upon that, is there issues with the type of algorithms that you're developing with regards to fair and generalizable? Because certainly systems are very specific as well, regionally and really very local systems, and certain different medical systems such as for-profit versus academic versus, let's say, a Kaiser or a VA system.
Yeah, so I mean, I think for us, even with any, like, even if you're building, for example, which we're not working on this, but like, let's say you're building a wound monitoring tool, and that's your very narrow focus. Even there, you have to worry about, you know, representation across skin tone, differences in how photography is done, what photographic tools are used, what for image capture, differences in lighting that might occur across systems, differences in like photo storage and compression that might have some strain. So like, I think no matter what problem you're tackling, whether it's diagnostic or not, you do have to worry about those issues. I just wanted to bring it up that I also want people to also think like beyond diagnosis, all these same problems show up in those domains as well.
So how have you addressed some of these problems in your particular domain?
So for us, we have worked hard to basically try to get diverse skin tones and to have that be a part of our data pipeline as we collect data, and to have labels, metadata labels with skin tone, which is its whole like complex realm in and of itself about whether those labels, you know, use the Fitzpatrick scale, which has some problematic features, whether that's done based off of a photo or in person, because lighting can affect how skin tone looks. So like every layer, it gets like a little bit more complex, and I don't want to necessarily overwhelm people, but these are the things that we think about. So when we try to collect as much metadata as possible on any images that we use, such as like skin tone, gender, age, geography, where it's taken. It's not always possible to know what camera was used to capture the image, but if you can collect that. And so I think being able to have as much metadata as possible so that you can make sure that none of these features actually affect performance is one thing. And I think the other thing is like working on multi-site, right? So reducing the chances that you're not going to have a generalizable algorithm by actually doing your testing in real world conditions across multiple sites. So those are the kinds of things that we think about.
And that's addressing non-diagnostic algorithms as well as diagnostic?
So as I mentioned, I work mostly in the non-diagnostic space. A lot of the research that I do in the diagnostic space is not quite in diagnostic development, but pointing out where diagnostic algorithms fail because of some of the issues that I've mentioned, and how that can lead to drop-offs in performance.
Yeah, and I think that's very important for especially the end users to understand the pitfalls of using these algorithms, because I think there's been a lot of fanfare and a lot of hallelujahs, and to understand that specific AI is highly specific, and that's why it's called specific AI. Trevor, have you faced some of these challenges, and how have you approached them and tried to get around them?
Yeah, so I agree 100%. I think, you know, when you look at how this all starts, the way data, like dermatology data, has been kind of historically archived and managed has been through diagnosis. So a lot of people went out and said, well, that's what we should start with, is we have all of these pictures with metadata labeled as diagnosis, so we should start to build diagnostic classifiers. But then you start hitting the, well, what about this diagnosis and what about that diagnosis? And it becomes an increasingly super complicated problem. So the focus of my research and development is on kind of non-diagnostic tools, because these machine learning algorithms are super powerful, and there are so many super interesting applications to fit them in a safe way and kind of existing patient pathways like virtual care, that, you know, you can make a difference, you can measure the difference, and you can very carefully like set the preconditions to which you expect the algorithm to be successful, and then you measure that. So I think that that'll be the next thing, is lots and lots of algorithms directed at, you know, things that aren't diagnosis. And it's like, it really is, it's like we set that space because, you know, so far everything that you see, you know, in popular literature and in a lot of, you know, interactions with, you know, computational scientists, it's focused on diagnosis because that's what the data is labeled as. But there's a lot more that we can do with that.
Can you give us some examples, Trevor, of some of the work that you're doing?
Yeah, so I'm looking at things that are targeted towards even like opinion-oriented artificial intelligence. I'm like, what if I could just surrogate a decision from a single dermatologist and use that to guide decision-making? It's not going to be perfect. I know it's not going to be perfect. But if we can define the preconditions under which we're expecting to use it and say, all it really has to do is say, shrink the assessment time in patients that really need it, and you've made a difference. 20 years from now, sure, maybe we can have, you know, super fantastic diagnostic algorithms that do everything for us. It's like, but for now, it's like, I think those little wins are really going to drive the next generation of dermatology assessments.
So in terms of augmenting management decisions, for example, is that what you're, yeah. Yeah, you know, we did a systematic review that's coming out in Lancet Digital Health to look at both patient and the general population attitudes towards AI in medicine, not just dermatology. And it comes to sort of the logical finding that people are comfortable with AI but want supervision, as Roxana mentioned. They don't really trust AI going off on its own. One thing is because right now the interpretability is not really very clear. It's kind of a black box. But as long as the clinician has the sort of overall supervision and is really being augmented, so to speak, rather than the AI taking control. And, you know, you're right, dermatology has so much more than just diagnostics, right? Diagnostics is the first step. And then we've got sort of decisions in management, treatment, and we look at the course, especially in rashes. I think up until this point, diagnosis has really been focused on single lesions, and it's been expanding to rashes, which is a little bit of a tougher challenge. But certainly in management, rashes is much more complex. And certainly diagnosis can be as well. And Sharad, do you have you've been working with a commercial entity. How have they addressed creating algorithms that are fair and generalizable?
See, so a lot of our focus, I mean, one can claim sort of algorithmic fairness or run sort of experiments sitting in front of a fast computer and iterating through things. But what we have tried to do, working with sort of our clinical partners, is to see that both determine and be very specific about how we sort of conduct our clinical studies. So for example, we published a paper a couple of months back, which was a 5,500 patient study. And this was sort of spread across sort of rural spectrum, which is sort of a large part of India, where the sort of the mobile app, which is sort of the front for the algorithms. So there it was the people who were doing the study were, let us say, non-trained dermatologists, but sort of more GPs. So, but addressing sort of a large sort of rural population in sort of camps, etc., that happen, those kind of things. A second setting was sort of a tertiary care, public health, sort of public hospital. And then there were sort of more of the upscale dermatology clinics that were sort of more clearly in urban areas. So what we did was, and obviously the skin type, even in India, kind of varies, but we were sort of focusing on a certain part of the country. So the physicians guiding were sort of saying, well, this is where it falls in the Fitzpatrick scale. And like Roxanne mentioned, there are limitations, but I mean, for something that has to commercialize, we have to use something as how we baseline. So using those things, we kind of said, well, this is the images, how the algorithm performed in sort of a rural setting across sort of these disease classes, how the algorithm performed in a sort of an urban setting across these disease classes, and then, or sort of then in the tertiary care hospital, which sees a sort of a wider spectrum of disease classes, because maybe the urban clinics see more what might be termed as cosmetic conditions to some extent. So they were a little biased towards, in terms of how the data set was structured, was sort of more, maybe more cosmetic conditions and maybe not so much what maybe the doctors would consider more serious conditions, etc. So that is how we would, and then make the study large so that it is statistically relevant. So that has been sort of our focus, to sort of build, substantiate our algorithms with sort of realistic claims of where they do perform well, and what are the skin types, and obviously making sure that the annotations, to the extent it is possible, make sure that they are accurate, so that when we publish our results, we are publishing sort of real data to match what we are seeing with sort of maybe the lab or a computer generated data running algorithms. So that has been the primary focus for us.
Great. So circling back to you, Roxana, you had mentioned that you do non-diagnostic. Can you expand a little bit for our audience and touch on what are the different areas that you're interested in non-diagnostically? Because I think most people do really think about AI and dermatology as diagnostics.
Yeah, so we with telemedicine have been working mostly on patient image quality. As we know, anyone who practices dermatology knows that the photos that we sometimes get are not really usable. And so trying to build things that can basically help patients take better photos, the same way like when you do e-check deposit, it helps you out, take a good photo of your check so that you can deposit it. So those are the kinds of applications that we're working on. And we've actually developed something, and now we're going to the clinic to do a clinical trial, which I think is so important, because developing an algorithm on your computer with like static images is one thing. Putting an algorithm in a patient's hands and seeing how that interaction actually happens is another. And I think that's like such an important part. So we don't know the answer to that yet. And we may find that we have to go back and tweak things once we actually do that trial, right? And so that's the sort of stuff that we're actively working on right now. And as I mentioned, like other work that I do looks at like taking existing algorithms and basically saying like how they break and why they break, and what some of those issues are. And so one thing I did want to bring up that we haven't really discussed yet for fairness and generalizability is labeling data, right? Like, and that's like another issue I want just people to be thinking about and to be aware of. Like, how do you decide that an image actually truly represents X disease? And we know from research done on the ImageNet data set that noisy labels can definitely affect algorithm performance. And these algorithms only work as well as the fidelity of their labels. And they're not magically learning to do the right label if they're given bad labels. And so setting gold standards for how we do the labeling, that doesn't really exist. People think that for malignancies we should use histopathology, but we also know that there's research showing variability in histopathology readouts between pathologists. But I just bring this up because from an industry standpoint, I have seen a lot of algorithms suggested from industry where dermatology consensus was used as the label for the disease. And as dermatologists, we all know that we, can't always diagnose a melanoma. I think the number is like, you have to biopsy like 1 out of 7 lesions before you have like a true hit for a melanoma. And so I just want people to also think about like label noise as another source of potential bias.
Absolutely. I think gold standard benchmarking is a real fundamental problem. And but with molecular medicine taking hold, I think there may be correlation with molecular data, which would be a little bit, I mean, we don't really know that that's gold standard either, but it's maybe getting a little, moving the goalposts a little closer. Yeah, I think that's an issue. I think some studies use consensus histopathologist diagnosis. But certainly there are many studies that show that single dermatopathologists can have quite variable reproducibility, and then intra-observer variability is also quite dramatic, much more than we would have thought as clinicians. But I think that's an excellent, excellent point. Yeah. So, and your issue, you really touched upon this issue of guiding clinicians to take images of high quality consistently. If we could automate that, that would be so much facilitate our databases and the quality of our databases. So do you foresee, for example, you know, our iPhones can focus automatically. Do you foresee, right now I hear that you're giving the photographer feedback for them to take another photo, but do you foresee the point where we can do that for the skin, automatically focus? For example, we do have that in a certain, there seems to be user variability in using that though.
That is the eventual goal, but right now we're still in the sort of development phase. But that is, you know, it's like the check photo taking, right? At the beginning, when we had that algorithm, it would give you, I remember, it would give you feedback, like,
right.
And then now you don't even need the feedback. It just takes the photo of the check for you. Like
That's
it just automatically. So like we see it going through like a similar iterative process. And I think, you know, that's the way we go with algorithms in general. Like even when we're talking about diagnostics, is like, right, like right now, I just don't feel like anything is good enough to, you know, work without a human physician in the loop from what I've seen. And so, you know, we start with the human physician in the loop, but then as we validate, improve, and like actually show that it's doing things well, we can become more automated. And I think that's like the medical, going back to your first question, like that is the medical iterative process. That's a little bit different from the software iterative process. Is we have breaks built into the system of the physician to come in and help make sure nothing goes wrong, but then we can use that process to maybe actually improve over time. And maybe there is a time where like the training wheels can come off, but we have to have really good data, like on large, diverse groups of patients that show that it's appropriate for the training wheels to come off.
Absolutely. And as we're winding up the last portion of the discussion, I wanted to address this issue of resistance to adoption. So our study, our systematic review of patients in the general population suggested that they're open to use of AI products. But how about the practitioners, the healthcare practitioners? For example, I know that there's been a lot of molecular tools that have come online for both histopath diagnosis and clinical diagnosis, but they haven't been widely adopted. And as a matter of fact, there's a lot of resistance, for example, in the pathologists at my institution for adopting some of these molecular tests. And I don't know very many dermatologists who have adopted some of the molecular tests out there for clinical diagnosis. So what about AI in these tools and in integrating it into the workflow? How do you all see overcoming some of these barriers? Have you encountered these barriers and how do you address them? Trevor, why don't we start with you?
Well, I think you have to start with what part of the pathway are you trying to improve? Because dermatology, we're not used to image capturing as part of our normal daily routine. It's like, so the instant you introduce a tool that requires that, you've introduced a whole spectrum of behavioral and psychological change that needs to take place before people are going to be willing to adopt it. I mean, even just simple teledermatology, it's like the studies say, well, if you get a general practitioner or healthcare provider to send a teledermatology consult. It takes like an extra 6 to 8 minutes on the front end and an extra 11 minutes on the back end to deal with it, which is hugely significant. And a lot of that has to do with kind of quality data capturing and inputting and setting those things up. And depending on the system that you're proposing using, so the time cost to clinicians can be considerable. So that leads to people going, well, unless I see a huge difference, I'm not going to do it. But unless you get people implementing and understand it, beyond the initial trials, unless you have 5 years to wait for a huge multi-center randomized controlled trial, people aren't going to use it, and you kind of get stuck there. So I think that's one of the big issues is understanding where in the pathway these tools can be best implemented, and then picking the best algorithms to impact that pathway. So like Roxana was talking about, telemedicine.
Yeah, where actually you already have fit to function collection of images. Those images are made for diagnostic purposes. Yeah, a huge problem with data sets is fit to function, I think. A lot of the photos taken in clinic have ink around them or rulers next to them that have to be cropped out in some way. Sharad, how about yourself? How has your company dealt with the resistance, or have you met any resistance?
Yeah, so certainly, I mean, we were not coming from this background, taken aback a little bit when there was sort of a poll among sort of dermatologists in India via sort of an organized body. And about 95% of the dermatologists kind of, and I think the poll was kind of structured as, is sort of AI in dermatology a boon or a bane? And 95% of the dermatologists kind of voted bane. So we were kind of taken aback. We were expecting a little bit of sort of resistance, given that, I mean, we were trying to say, well, now for certain conditions, the GPs are enabled to do a better job of diagnosing or a preliminary diagnosis of skin diseases that their patients are seeing. But, and as we kind of dug deeper, I think it was sort of contrary to what I would have originally thought. The older doctors were, from an age point of view, were more welcoming of the technology development, the more experienced and maybe age-wise older, whereas the younger doctors kind of saw it as more of a threat, where I would have thought that maybe the younger practitioners would be more open to sort of that kind of adoption. Over sort of talking to several of them, it turned out that people who were sort of starting their careers kind of maybe thought that something like this, or maybe there's this sort of general sort of apprehension about AI that suddenly the GPs will be able to perform as well as dermatologists if technologies like this were sort of made available, whereas maybe the older doctors with sort of more secure, grounded practices did not see it so much of as a threat. So that was kind of our experience, and we are kind of working with both dermatologists and GPs to sort of address maybe the larger public health problem in India, where there are just not enough dermatologists, and the GPs we are targeting are sort of more in tier 2, tier 3 towns or villages where really there is no access to good dermatologists. So capability like this may prove of value, but that sort of learning is taking time, and certainly the initial reaction was a bit unexpected.
Very interesting. Thank you for sharing that with us. I see that we need to wrap it up now. And thank you all for joining us. Thanks to our audience, and thanks to AIMMED for hosting this.
Thank you.